Chapter 22, Psychiatric Emergencies, Part 2. Another problem we may run into is acute psychosis. By now you should remember that acute means sudden onset, and psychosis is a delusional state in which a person is not in touch with reality. There are a couple of different causes to this, some of them being psychological disorders themselves, such as delusional disorders or schizophrenia. Oftentimes we can see people who are under intense periods of stress or who have taken mind-altering substances who kind of lose touch with reality. Schizophrenia is a disorder that while there is a diagnosis and a name for it, it's actually kind of hard to define and to categorize. Normally we see that onset of schizophrenia in adulthood, so you're not often going to see children or adults, though it is a possibility, of course. Often there will be brain damage or psychological and social influences, even genetics, so patients who had parents or family who were diagnosed as schizophrenics have a higher probability of receiving the same diagnosis as well. Some of the symptoms of schizophrenia include delusions and hallucinations, both either visual or audible or both. They're just very not interested in anything that brings them overall happiness or pleasure, and an erratic speech pattern. Some of the general guidelines that we try to put into place when dealing with a psychotic patient is first, scene safety. Ensure that you are in a safe position and have an exit plan. Identify yourself. Make sure that they know that you are medical and not law enforcement. Be calm, direct, and straightforward, and maintain an emotional distance as well as that physical one. You are not there to become their best friend. You are there to provide them medical care in the moment. Don't argue with them. Also, don't play along necessarily with their hallucinations or their delusions. Don't tell them they're not existing, but don't pretend, oh yeah, I hear it. Do you know what it tells me? Blah, blah, blah. Just acknowledge that they say they have it. Oh, okay, so you're hearing things, or oh, okay, so you see things, or you said you saw this. But don't be like, oh, that's totally fake, or oh, I totally agree. You may need to call in a friend, their friend, a family member, somebody that they trust. I ran a call one time of a woman who was having a psychological crisis after having a car accident. And while she was uninjured, because of the breakdown she was having, we were actually on scene for 2 hours to calm her down and to get a friend on the scene to assist us without significant trouble. Another issue you may run into is a patient who is experiencing excited delirium. So delirium is an impairment in cognitive function. They may appear disoriented or have hallucinations or delusions. So, obviously it may present the same as schizophrenia. There's some agitation that they will often display, maybe restless or irregular physical activity. They may strike out. So you may end up at a higher risk of safety concerns and safety issues that arise. Some additional symptoms that you'll see is hypertension, tachycardia, sweating, because when you think excited, you're an increase in activity, dilated pupils, and some vivid hallucinations. How do we treat excited delirium? Again, scene safety, personal safety, a #1 priority. And then we're going to provide them honesty, respect, give them distance, making sure not to be too physically close, limit your physical contact with them, and don't leave them unattended because they can become a harm to themselves or others. Try to determine a patient's orientation. Are they alert and aware of time, place? What's their concentration and judgment? Now, this isn't, give them puzzles and ask them to figure out riddles, but you do need to figure out their mental state and their level of alertness. Look at their communication, how they communicate, the words they use, and their appearance and dress. If you're at their house, does it appear that they're taking care of things, or does it appear that maybe things have been not taken care of for quite some time now? If this is a medical in terms of an overdose, obviously we need to treat the overdose. If this is delirium as the result of that substance abuse, we need to take the bottles or substances, if we can, safely with us. And when we transport these patients, don't use lights and sirens, because it can actually increase the stress as well. You need to consider whether or not ALS assistance is needed for what we call chemical restraint, so drugs that calm them down, because this uncontrolled agitation could lead to sudden death due to extreme hypertension and tachycardia. Of course, we need to consider restraint, and we've talked some about this. If the patient is going to present as a significant harm to myself or to themselves, then restraint may be appropriate. We need to consider both why we're doing it and the method we use to restrain the patient, both in the practice and the physical restraints we actually use. You need to work as a team to do this, and you need to do so appropriately. You need to be able to explain why you restrain the patient. You need to be able to justify it too, because restraint, especially when it is not necessary and when it is causes harm to our patient, can obviously lead to significant issues and lawsuits. Your goal is to only use restraints when you have to protect yourself from the patient and protect the patient from themselves. So you have to be able to show how they were going to be harmful to themselves, to you, or to others in order to justify using restraints. I think the most important term to think about is the term reasonable force. You have to be able to explain why you used force, and it has to be a reasonable amount of force for the patient, the size of the patient, etc. You obviously want to follow your protocols when it comes to restraining your patient. And if law enforcement is there, involve them. A, because they restrain people quite frequently, and B, because if this does become a legal matter, you've got these people here who are witnesses who can support you. Ask the family to assist. Don't immediately think, oh, I've got to restrain this patient. It's possible they just need somebody to de-escalate the situation for them, someone who they trust or someone who is able to keep them calm. Consider the need to restrain quickly so that you are not putting yourself in harm's way for any longer than absolutely necessary. You need to have enough people to be able to restrain the patient safely, and that's normally one per limb. And you need to all be in on the plan so that you're all doing the same thing for the same reason, which means that, when you say go, everybody knows what their role is. And again, reasonable force is the most important part here. And what you are likely using is the backboard and the spider straps. But like you also saw when we did lifting and moving, that might also be, it may be better to use the reeve stretcher more to wrap them up and then secure them as well. Level of force is obviously going to vary, but your goal is to use as little as possible. You've got to look at the patient's sex, size, their mental status, their strength, We do know that when somebody is in a psychotic episode, there is the potential that they will display a superhuman strength, for lack of a better word, because of the fact that they just aren't in right mind and will put more strength than you would expect. But you've definitely got to consider all of these factors, and you've got to do it quickly, because if you take too long in developing a plan, then your patient will become even more agitated, and it may be even harder. Make sure you're talking to the patient. Make sure you're providing them information and you're giving them that heads up about what's happening. Now, that doesn't mean that you say, hey, we're going to restrain you right now, but hey, let's be calm. Hey, all we're going to do is get you help. We're just going to, secure you so we can transport you. Treat them with as much dignity and respect as you can, given the circumstances, and document everything, of course. This does say avoid direct eye contact, because in some situations the patient may take that as more of a authoritative thing, somebody trying to play power, that whole, why are you looking at me? But instead, you have to read the situation. Some patients may appreciate direct eye contact. Some patients may prefer you to look them in the eye as you're talking to them. And when you have restrained them, do not leave them unattended. They shouldn't be restrained on their stomach. You should have them on their back when you're transporting them if they're restrained. And you should attempt to use 4-point restraints, so both arms and both legs secured appropriately. If not, they may actually come out of the restraints and become more of a harm to you and your crew. Once restrained, always monitor your patient for vomiting, for the potential airway obstruction, and their respiratory status. A lot of what you hear story-wise about patients who have gone into respiratory arrest or died while in restraints, it's because their respiratory function failed and they weren't being monitored appropriately. Monitor for levels of consciousness changes so that if necessary, you can unrestrain them and treat them as needed. While violence makes up a very small part of the psychological emergencies, we do need to always be cautious and aware of the potential for violence to occur at these scenes. And it's not just from the patient. It's possible that someone in their life is actually going to become more violent. And sometimes that just becomes the worry and the fear. You've got to wonder and ask, is this somebody who has had a history of becoming violent? If this is a frequent flyer, somebody that we've run a lot, it's possible that dispatch will provide that information. And if this is a known aggressive patient, then they will likely have dispatched law enforcement. Learn how to read body language and their posture. Are they tense and rigid? Are their fists balled up? Do they look like they're ready to get physically violent with somebody? Are they pacing? Are they sitting or standing? Do they look like they're ready to run? Again, are they near anything that is dangerous or could be used as a weapon? Do they have it in their hand? Again, if at any point this becomes something that you're worried, don't be afraid to bring in law enforcement. How is their speech pattern? Is it loud? Are they being aggressive? Is it bizarre or overly emotional? And is it a concern, of course? Their physical activity, of course, is their most telling sign of the potential that they're going to become violent. So, as I said, clenched fists, pacing, angry, pushing, throwing things. These are all going to be signs that this scene may become a bit more chaotic and more violent the longer you wait. Is this a person who has a history? Is there a history of drug abuse or depression? a history of attempts of suicide previously? Or, do you have a history of coming to this and being at this house? And do you know this person? And if so, can you talk to them? Do you know their history? And be aware. And just because someone has not been violent before does not mean that they will not be violent now. So always have an exit strategy. We will unfortunately run those suicides and the attempted suicides more frequently than we want to admit or than we want to consider. The threats of suicide versus the actual attempts or successful attempts. We can't say what is a cry for help or what is just a cry for attention. Our expectation is to treat every attempt or every verbal comment about attempting suicide as a legitimate need for assistance. Whether or not it was, whether or not it was overly successful or just a small act, this is somebody who obviously needs to get additional help, and it's our job to help get it to them. There are a lot of warning signs, and unfortunately, there are also some people who will exhibit not a one. You have to use caution because of the fact that it's easy for somebody to say, I wish I'd known, I wish I'd seen, or I wish I'd paid attention. Sometimes people won't display any of these signs, and then sometimes they display all of them. Some of the things to consider include somebody who just does have that feeling of hopelessness. Family may report that they've avoided eye contact. They've not been able to talk about the future, that they have suggested suicide or talked about how they would commit suicide. They have a plan. Somebody who has a plan about how they want to die and who gets what, that's obviously very concerning. Someone who feels trapped, someone who has attempted suicide previously. About 80% of those who are successful in committing suicide had actually attempted before. People who are older than 40, who are single or widowed, divorced, men older than 55, somebody who experienced a recent loss of a significant other or loved one, someone who has lost their job or experienced a significant financial setback, someone who has just received a bad health diagnosis or a fatal health diagnosis. And these are all concerning, and these are all potential people who may be contemplating or attempting suicide. When you're at a patient who is suicidal, so they have talked about it, but maybe not yet tried, maybe they've been saying they want to, and so their family has called 911, you also need to consider, if this person, are they within reach of a tool that could be utilized to attempt to kill themselves? Obviously, we don't want them to get their hands on it. Is there evidence of a self-destructive behavior? Have they been cutting themselves? Or, is the family reporting that they have increased their alcohol intake or their unsafe behaviors? And have they made an imminent threat of, I'm going to do this right now? Each of these are concerning, and they are an increased risk for you and for the patient. Do they have a medical problem, or are there some cultural and religious beliefs that maybe are conflicting for them? Something that drives them because of the divorce or because they aren't able to do something that their religion or their culture believes is driving them to feel they're not worthy of still being alive. And then unfortunately, we do have to be concerned that those patients who are suicidal may be willing to take out others for the sake of of successfully dying. And so they may be willing to do death by law enforcement, so go out because they're shooting at cops, or trying to take a cop out and hope the cop will kill them first. Or they may be willing to wreck a car that has other people in it just to be able to take their own life. And all of these are concerning, obviously, and all of these are reasons why when we have a patient who could be suicidal, we need to take it very seriously. We continue to see an increase in the number of patients who are experiencing post-traumatic stress disorder, especially returning combat veterans. But it doesn't just take combat to get PTSD. Patients who have experienced trauma, whether it's direct trauma that they've experienced or trauma that indirectly they've experienced. It may have been trauma in their past. It also could have been trauma that is recent. So, it's a concern, but we don't know when or how or who is going to be impacted. After 9/11, we saw a lot of people who actually were experiencing PTSD, even though they weren't in the towers or at the Pentagon. And a lot of that is the result of watching it over and over again on the TV. War, loss of a loved one, and just in general stressful life changes are all events that may lead to a person experiencing traumatic stress. At some point, 7 to 8% of the general population will experience PTSD. And, I think we are all aware that those who have served in the military have a higher chance of experiencing it. Some of the symptoms that we see in PTSD patients are hopelessness, anxiety, anger, and not just normal anger, but a heightened level of anger, and fear. Patients who have a history of PTSD or who have a diagnosis will definitely try to avoid the triggers. So you see it a lot around the 4th of July. A reminder that those who are veterans don't normally like fireworks, the loud noises, specific smells, anything that's going to remind them of the traumatic event or events. They're in a constant state of arousal, and they may have flashbacks or general thoughts or nightmares that cause them to relive whatever event or events cause them that trauma. We see a higher incidence of type 2 diabetes, an impact to the long-term brain function, traumatic brain injury, and early heart disease in combat veterans, especially those who have PTSD. You've got to use caution. You've got to, be able to emotionally handle the interactions with combat veterans who are experiencing PTSD. A number of TV shows have done scenarios regarding veterans in a PTSD crisis and how to handle it. Obviously our goal is to treat them with respect, to treat them with dignity, to respect the personal space, but ultimately our goal is to get them help. And unfortunately in a flawed system, it may not be as easy as it sounds, but your job is to get them somewhere where they can hopefully get help in the long term. Make sure they don't have access to a weapon, and when possible, try not to use restraints because it can actually escalate the problem. So, our goal is to transport them in a position of comfort without having to restrain them. Some of the legal considerations that we'll come across when dealing with people in behavioral crises. It is well, first off is, are they able to give consent or refusal? And so we have to sit there and we have to build their confidence in us and their trust in us to really be able to talk to them and to get the consent. You know, is it immediate need that we need to get them to the hospital? Possibly that we need to get law enforcement involved? Or is this something where we've got some time? You know, obviously life threats are going to be an immediate. Life threats are going to take priority. But if this is truly just a behavioral emergency, then we don't necessarily have to worry about ABC. When our patient is legally unable to tell us who they are, where they are, when they're not able to provide appropriate refusal or consent, we're going to work towards implied consent. Because we would assume if they were not in their psychological crises, that they would say, yes, please help. Unfortunately, in the psychological emergencies, we may find a need to involve law enforcement, especially if our patient has threatened self-harm. You know, we don't really have a legal authority to put a patient under our care if they're not in a medical emergency. But if they have presented as somebody who is threatening to harm themselves, that's actually when we do have some ability to involve law enforcement. But if they're just in a psychological crisis, but they present as competent and aware, and they have no medical emergency, they can refuse, which is, of course, always concerning. You know, the court of law is where we're going to get our most help for somebody who is competent, but maybe you're concerned about their psychological well-being. We need to err on the side of treatment and transport. We need to, when in doubt, call medical control and involve law enforcement so that we can make sure we're getting smart choices made so that we can, you know, in the long run, provide the best care to our patients as possible.